supplying the direct blood to the aorta, and now it ceases because of the pressure, because the lungs are now working. And now the third thing which closes is the foramen vein. So the foramen vein is patent, and in first 24 hours the things change, and you will see it gets red. So instead of being patent, you will see in a minute that it turns to red, and that's what it closes. The whole physiology of this cardiac system is interesting to understand, and that is why we need to know certain factors like the four-chamber view, the outlets, because this is very important. Now, why the fetal cardiac ultrasound is challenging for all of us, and Professor Wellesley of the United States did a study and said, if you have a 20-beat heart, you will find it at the size of a dime. हमारे पैसा भी है जरा बड़ा होगा, उनका dime से भी छोटा होता है, half the size of our पैसा by the way. So the dime is very small, and 20 beats, it is interesting to know. Now the developing heart from 21 to 35 days is a very interesting and phenomenal changes which takes place in the endocardial tube formation. The reason to show you these animations is to make you aware of how the things develop so that we concentrate on certain points. So this is how the heart chambers are formed, and that's why we have outlets and the four chambers, the most important information to get on ultrasound. So heart anatomy and image orientation is the next thing which we are all interested in. It all depends on how the fetus is lying inside. So I'll show you a number of positions, as you can see here. The best position would be that the baby is facing the transducer. So if you find that the spine is facing the transducer, you might have to defer the exam, and that's why we prefer that we do the scan at around 24 weeks and 26 weeks, because the fetus can move very fast, and within that timing of our scanning we might see everything. But if you tell me to scan a 38-week fetus with the spine front, even Dr. Musarraf may miss something in that scan. So these are the various scanning planes where pointing out to the spine and the facing. And if you look at this picture, this is one of the most complicated pictures. And I always say on this scan that if you start learning fetal echo today, it will take you 2 years to master it. And when I say 2 years to master it, means you can appreciate all those positioning and how the heart would look like in these positioning of the fetus. So it's not an easy thing. If you start from thinking on doing fetal echo today, yes, you'll pick up four chamber, you'll see outlets, but to master it, you might take almost a year or 2 years to really, because of these positions. And these 8 positioning of the fetus is translated into 16 formats of the heart, which is again a very complicated thing to understand, which normally when we do our course for extended course in Karachi, we teach them each and every section. But in this 2-3 hours, we won't be able to do that. So of course, now let's talk about the four-chamber view, apical view and subcostal. When we talk about four-chamber view, we talk about apical view and subcostal. What is the purpose? The purpose of the uses is identifying moderator band in the right ventricle, Doppler imaging of mitral valve and tricuspid valve above and below the valves, and identify the superior pulmonary vein entering the left atrium, identify the foramen flap entering the left atrium. These are the uses of tactical view of the four-chamber. The other uses are angle transducer posteriorly to obtain the five-chamber view, which we are going to show you each and every one, and the Doppler imaging of the aortic valve above and below the valve. So we are going to show you images of every one of them if we are talking. Now this is not my slide, this is the ARUM slide, and why I want to insist on this slide is that I'm not going to take anything from my side. I'm going to strictly follow the rules which have been laid down by the ARUM. Four-chamber view is the most important, so this tells us just beating heart is not sufficient. Heart size, rate and rhythm, axis, position, situs, diffusion, hypertrophy, intact intraventricular valves, offset and symmetrical heart chambers are important to see in this. Now we have this schematic diagram, and it shows that we have got two ventricles, left ventricle, right ventricle, atrium, and the left atrium has got these pulmonary valves. The most important thing which we tend to miss in the scan is looking at the spine and the aorta. Aorta is your backbone to many abnormalities which we never pay attention to. The four-chamber view, fine, very good, no problem. So this is the representation of the same, that is the heart, the left ventricle, left atrium, the tricuspid valve, the mitral valve, LARA, and that's the aorta. So aorta is always on the left hand side, which tells you where we are. So again, let me go back to this slide. That's the slide which I wanted to talk of. Okay, I'm sorry, I didn't read it fast. So we will stop at this slide. And there you go. So with this view, we are still seeing LV, RV, RA, aorta, but we are also seeing a bulge, and that's the flap of the foramen vein, which can be seen most of the time. Now let's show you the image. I'm only on one side, so my pointer can only point on this side. That's a four-chamber view. Sometimes it's an eyeball technique that this is 1/3 of the chest. One way to know that the size of the heart is normal. The brightness of this monitor is slightly low. That one is slightly better on the right hand side, but you can see the tricuspid, the mitral, the intraventricular, and the four-chamber view of the heart, and that's the transverse of the chest. Once we do that, we stop at this point and we can calculate the circumference of the chest, and we can calculate the circumference of the heart. So you note down and divide. If it is less than 1/3, that means it is the normal. So that's how we really trace with the circumference, and there you can see I'm tracing with the circumference, and I can tell you that it is 1/3, which means the size of the heart is normal. Anything which is large, we are going to talk about the clinical aspect at the end. I'm just trying to show you the structures. Now when we do, look at this aorta right here. When you divide the chest, the line which you draw, the dotted line, should just touch the aorta. That's very important. And then you divide it into half and half, and then you put the dotted line on the intraventricular septum. So the axis is okay, the size is okay, and the last thing which we do is we measure, we make a dotted line on the tricuspid valve and the mitral valve. Tricuspid, when you make a line, is 1 millimeter below into the right ventricle, and the left ventricle is slightly above, hardly a millimeter. Now how do you measure millimeter? It is very difficult. So when you draw a line, the flap of this would be on this side of the line, and the flap of this will be on the other side of the line, which means 1 millimeter. So you don't have to worry about 1 millimeter, very difficult to measure. So I'm just putting the line on that ratio. So here we have our 4-chamber view, schematic view, just to highlight what we were talking about. And this structure which you see tells us that this is the right ventricle, and that is modulated back. So if you start to see that bright echogenic line in any chamber, tells you that this is the right ventricle. That's a very important landmark to look for. And then, of course, you have a flap. You have a flap, which is the septum of the oxygen and the septum of the secundum, and that tells us the bulge on this side. That means the foramen ovale is patent. So this is just to give you a still slide. And now we have the live recording. The live recording tells us which one